Thank you for watching this DVD. This is part of the training information for the AIM trial looking at two treatment options for unstable ankle fractures in older people. This is an equivalence randomised controlled trial, and unlike most RCTs, it's not looking to see whether one treatment is superior to the other, but rather whether they are equally good. This can be really important sometimes when you need to respond to either a preference or a concern from patients or surgeons about the treatment they receive. It may be also important in terms of cost effectiveness. Patients may have a strong preference to either avoid surgery or because they have a perceived limitation in their functional needs. Surgeons may have concerns about the injury to the soft tissues or the quality of bone they're likely to encounter at surgery. Let me tell you about the AIM study. I don't think there is much debate about what orthopaedic surgeons would recommend for treatment in young patients with unstable ankle fractures. We aim for surgical reconstruction, early functional recovery, and a lower long-term risk of degenerative change. But with age, from a surgical perspective, several things change. Firstly, bone quality deteriorates. Indeed, ankle fracture is a marker diagnosis for osteoporosis. And with that comes less reliable implant fixation and less confidence in maintaining reduction and confidence in early mobilisation. Secondly, skin vitality diminishes and there is the risk of impaired healing and therefore implant-related infection. In order to quantify some of these risks, we have previously studied the limb vascularity and particularly the transcutaneous oxygen saturation in the skin around a fractured ankle in an older person. And there is an issue with skin vitality. There is a consistent correlation between impaired skin microcirculation and the failure of wound healing. Unfortunately, this can't be detected by normal bedside investigations, and it doesn't relate to large vessel disease that we could normally test for. And from the osteoporosis perspective, we recognise up to a 10-fold reduction in implant fixation strength between the ages of 50 and 80 years. Historically, in the absence of a reliable alternative, as a profession, we have tended to recommend internal fixation surgery, accepting that operating on an older patient's ankle fracture is associated with a higher rate of complications. Previous studies of the alternative, non-surgical traditional casting, have reported an unacceptable incidence of loss of reduction, and casting has its own skin problems. However, a casting technique, total contact casting, has been practiced very successfully for many years to treat leg ulcers in diabetic patients who have the frailest and most vulnerable skin. It works by being applied intimately to the whole of the lower leg, dissipating load evenly over the greatest skin area, protecting and promoting ulcer healing. In pilot and feasibility studies, a modification of this technique has been used successfully to treat unstable ankle fractures in older people. We call this close contact casting. The casting technique is quite similar to what orthopaedic surgeons are used to, but there are some important differences. Close contact casting is characterised by placing specific pressure pads at certain loading or fracture moulding points. Over the remaining area of the cast, there is very minimal padding. In the next part of this video, my colleague Bob Handley demonstrates and discusses the preparation, application technique, monitoring and removal of close contact casts. This technique video is only one part of the information you need to apply this experimental intervention to patients. You are required to have wider information and an interactive demonstration teaching session with one of the AIM study research team. You can of course use this video to refresh your memory of the technique of close contact casting if it's a while since you applied one. Thank you.